I took Mark's charge to heart to discuss ethics. So I'm not going to talk about my work today, but more about some of the ethical challenges I've faced working in India. And this is just an example of one of them. So I'm going to talk a bit about the disclosure of individual results to study participants in the U.S. And the status of disclosure of individual results to study participants in India. And then I'm going to address some of the discordances between what happens in the U.S. and what happens in India, and then talk a little bit about future directions. In the brochure, they gave me an honorary PhD. Just want to take it. The title in the brochure is Study Subjects, and I'm terming this Study Participants, and that kind of describes a little bit of the differences between how I feel research participants are viewed in the U.S. and India. So I want to start with a hypothetical case for the United States. So we have a population-based study examining risk factors for HIV on the south side of Chicago. And this has been done in various settings in the U.S. The study includes a survey and then HIV testing. The consent form states that participant data will be unlinked to test results, and those interested in HIV status can visit one of several free HIV counseling and testing centers. So I just want to, so people soak that in. It's not, a complicated study, but I want people to consider: is there a ethical or moral obligation to disclose test results to study participants, and is there a legal obligation? Now, if the consent says you can join the study, we will survey you, and part of the study is an HIV test. It's anonymous, and we don't give test results as part of this. But there are 3 clinics, in your neighborhood that give free test results. Is that appropriate? So just raise a hand. Appropriate? Inappropriate? Appropriate? Okay. Yeah, question.
So they would have to get tested twice if they want to get test results, or their clinic is going to provide them with the results?
So they would have to get a second test. Okay. Yes?
So from a study protocol design standpoint, could you have asked for an oral consent where you would have no way of linking the actual individual data and given a number for the OraSure result that you don't know who that person is, where they could have theoretically anonymously gotten their screening results from their primary trial?
Sure. I don't know, because I don't know if you can get oral consent for a detailed survey that's ask sensitive questions. And
this is one of the reasons you would, especially if you're going to be asking about information that was potentially illegal, like I don't know, having unprotected sex in public parks. That's an illegal activity. Having a name associated with that could potentially interfere with, and so that if you build in with your oral script and within your questionnaire certain times that if you're uncomfortable, would you like to stop, that there have been programs like that done.
Yeah. I'm unaware of any population-based study that does oral consent, but that there may be.
I was just thinking, because I do think that maybe in Chicago, where you only have to go 3 blocks to get a free anonymous test, that might be more okay than if your only alternative is, let's say in a small town, to go to the Planned Parenthood, that it's by name, and it's stigmatizing just to walk through the door.
Sure. Absolutely. And this is further complicated by the need, most population-based surveys in this day and age are doing minimally invasive testing, and the need then for confirmatory testing. To get a true, HIV up or down status. All right, so a little bit of discussion. It seems like people are leaning, we've had some people say this is fine to do, and some people say maybe not so much. I'm trying to see who wins, though. I need like.
So, John, and you have informed as part of the consent process, people understand this is part of participating in the survey. So it's another way in which, appropriate or not, what you've done is to tell people what's going to happen, and then they are able to make that choice. So, from the IRB perspective, again, that's the first principle, and that one you've honored.
Yeah. So that's the question: is if you tell somebody in a consent that we will test you for HIV, but if you want to know your results, you have to go here and get tested. Is that appropriate?
So it's legal as per the Code of Federal Regulations to answer Renslow's question, but
Right.
I don't know about the first two tenets.
Okay. Yes.
I'd be worried about it because I think that, especially if the physician is the one getting the informed consent, there's a lot of studies that show that patients are more likely to participate in studies. They think that there's some benefit, there's an expectation, fear of disappointing the physician, fear that the physician may treat them differently. And I think there may also be a problem with their understanding, because I think that's a confusing concept. I mean, even here, when we understood what you were saying, we were like, well, does that mean they have to get a second test? Do they have to go? And so I'd be worried about placing an undue burden on them if they actually want that information, and how that might change the dynamic of their relationship with their physician.
And John, I'll take the opposite, so the investigator or the public health side of the argument, which is that the knowledge gained from this type of survey from others is actually meets beneficence, that is, could lead to valuable information for design of further prevention efforts, exactly targeting the population that's being studied. So where the question John raises is for the individual, there is a greater good being served that, again, is a subject of the IRB review and also in the minds of the investigators. That doesn't mean it's always the case, but I'm just saying that's an argument actually for the whole purpose of the study in the first place.
Okay.
I just wanted to say, to play devil's advocate, you could have the exact opposite as well. Patients who consent to the study may believe that because they weren't contacted, they may not really have a full understanding, and they may believe that because they weren't contacted, they weren't encouraged to get further testing, that they're negative.
Sure.
And then so that might actually dissuade some people from going on to getting testing.
Right. I mean, there's a lot of data in the U.S. that, when patients walk into the ER and they get a blood test, they just expect that an HIV test is part of that, and may not know that it's not as well. And then the question about providers. I mean, a lot of these surveys, thankfully, could work both ways, but are research staff, so our population-based door-to-door, usually students. But yeah, that is important if there's someone who the participant knows previously or is affiliated with. Yep.
It seems to me that legal obligation would depend on what specific jurisdiction you're in, and to some extent, ethics morality might be local also.
Okay. All right. So the World Medical Association's Declaration of Helsinki, and I'm not in. I dabble in ethics, but remind me, we don't follow Helsinki anymore. Is that correct? Okay.
We follow the International Conference on Clinical Practice.
Okay. All right. That's too bad. Well, the Helsinki. This is not really. This is more talking about. Well, I'll just read it. Patients entered into the study are entitled to be informed about the outcome of the study and to share any benefits that result from it. For example, access to interventions, et cetera, et cetera. So this is more talking about the results of the study in aggregate. Okay, so not an individual's results, but more of, this study found this. This may be of benefit to you if you have that. The Council for International Organized Medical Sciences is affiliated with the WHO, and it states that before requesting an individual's consent, the investigator must inform the research subject that he has the right to access his data on demand, even if the data lacks clinical futility. Okay? And so this provision assumes that the individual does, in fact, have the right to access his or her pertinent health data.
Wait, you need
Utility, I think.
no F, right?
I'm sorry, yeah, you're right, yeah.
It may well.
The AMA states that clinical investigation provides that in conducting clinical investigation, the investigator should demonstrate the same concern and caution for the welfare, safety, and comfort of the person involved as is required of a physician who's furnishing medical care. So basically, would you give your patient that you do HIV testing on their results? And you're obligated to do that. And so this could be interpreted as requiring disclosure to the patient of clinically significant findings. AMA also states that the physician must recognize that the patient-physician relationship exists and that professional judgment and skill must be exercised in the best interest of the patient. So these provisions suggest that medical ethics mandates disclosure of clinically significant results when such disclosure is in a research participant's best interest. And you would argue that HIV testing results are in a participant's best interest. So why not disclose results? So, one could think that, a specific result would increase participant distress and cause, emotional distress and damage. There could be little clinical significance. So if I'm doing tests that, of some random marker that has no known clinical significance, if I tell somebody the results of that, will that confuse them more? Will that seek additional testing leading to additional false positives and harm? Clinical futility, so even if they know the result, there's nothing that can be done about it. And then cost. It's costly to disclose results, to bring people back or to communicate it. There are ways to make it more cost effective, but generally there is a cost associated with it. And with HIV testing, as opposed to some other testing where there's necessary post-test counseling and then referral to care, you can imagine the cost would be a little higher. And then just getting back to, if non-disclosure is stated up front in the consent process, does that suffice? So in the U.S., there's really no federal guidelines that provide guidance to this, but the National Bioethics Advisory Commission, NBAC, says disclose if any of the following: the findings are valid and confirmed. Okay, so this is not some potential gene that might be causing X disease. There's something that's well established. Significant implications for subjects' health concerns. Okay, or a course of action to ameliorate is readily available. So support for this statement is that the prevalence of distress from disclosure is low. Okay, so certainly there will be situations where distress occurs, but overall it's low. Both the incidence or the prevalence of distress as well as the magnitude of distress. And that's from a couple studies. Even if there is distress, benefits seen amongst participants from results disclosure. So if you ask a participant who is distressed, was it okay that we distressed you? They'll be like, well, on the whole, I like knowing the results anyway. Even if little clinical significance or clinical, or if there is clinical futility, it may be personally meaningful to a participant. So ultimately, these two authors from the NIH bioethics group state that it would be disrespectful to treat research volunteers as conduits for generating scientific data without giving due consideration to their interest in receiving information about themselves derived from their participation in research. And then getting back to, again, is clear consent enough? So consent states that participant data will be unlinked to test results, and those interested in HIV status can visit one of several free HIV centers. Do participants who desire testing results have the option to not participate? And again, these authors suggest that respect for participants operates independently from the informed consent process. Investigators cannot use informed consent to waive participants' rights and should not use informed consent to disclaim ethical responsibilities. What about the cost? I've alluded to this. There can be significant, and we're not even getting into studies where, or a trial looking at an intervention where if someone is found to be HIV positive, then there's even the discussion of should then care or other treatments be offered. We're just talking about provision of test results, but there is costs associated with this, and significant costs could be attributed to this in settings that have limited resources, like India. Needs to be a trained counselor for post-test counseling. Can results be justifiably withheld? Maybe. So the bold is mine if it predictably compromises the safety of a participant or a third party. So in a misattributed paternity, in the case of a couple with a history of domestic violence, but it would have to be predictable. Okay, so it can't be suspect or maybe. Yep.
But on the other hand, your failure to disclose certainly could put third parties at risk because the primary person is not aware of their own status and is potentially exposing their sexual partners or shared IV users to risk that you knew about.
If it's, because the survey you're asking, are you having sex with your wife?
Right.
That sort of thing.
I think you could just as well say that the third party is at risk and you know it.
Right. Any other comments?
Or they could be pregnant woman.
Sure. I mean, there's, there are lawsuits in this country that occur because results aren't given. Yeah.
So when people enroll in a research study, they may be willing to provide you information about themselves that they themselves don't want to know. I mean, they may, and if they were required to receive the results of testing, they may not be willing to participate.
Right. Yeah, no, that's a good point. And it's in this case it's so nuanced. I mean, it's hard to conceive of this sometimes in a consent form and explain that this could be something that happens to a participant. I mean, there are a lot of and it's a little more complicated with genetic studies as well. But no, absolutely, that's.
I guess the question is then from a regulatory perspective, should an IRB, in other words, does it have to be a stipulation of participation in a research study that one is willing to receive information back about themselves? And it becomes more tangible when we're talking about test results. But what if it's a screening for dementia? I'm willing to answer those questions for you, but I don't necessarily want you to call me up and tell me I'm demented.
Right.
Or that I have depression, or that I'm in the lowest quintile of income.
Right.
And we kind of treat the biological measures differently. But at this point in time, as far as I know, IRBs are not necessarily required. We do allow people to opt out of receiving test results.
Right. And this is also true in, I mean, how much do you follow people up and bug them about results? In the case of HIV testing, giving someone the results is really important, and so we feel that it's important to follow them. But people may not want the results, and the ethical guidelines are usually describing this in the setting of patients have the right to get them versus to opt out. Yeah.
Yeah. In the history, if we take this out of the research context in the state of Illinois, as you all know, when the laws were first written, the ACLU was part of that process. This was really, so was I as part of the Illinois AIDS Advisory Council, and that led to, and this was at a time when there was no antiretroviral therapy, so the weight of the knowledge of the test and all the potential negative consequences were the same as they are now, but there was not a health impact of the benefits for the individual in terms of therapy. There certainly was for reducing the possibility of transmission. And so an informed consent process was brought to bear for exactly this reason, so that a person could choose yes or no to have that test because of the potential for damage or the implications. And that's all changed, at least in part, because of the availability of effective therapy where there's clearly a benefit to the individual to that knowledge.
Sean?
I mean, I think in general important to make a clear distinction between what we do at the bedside and when you're doing some of these research studies. I mean, because with the research studies, you have a hypothesis that you're testing, such as you come to my office, I see you, I want to treat you. The intent is not really to treat. So when you have results from some of these hypotheses that you are testing, they may represent like jargon or unproven results that, I don't know whether it's always necessary to share that with the patients.
But in this case, you're talking about an ELISA, right?
Yeah.
You have
Yeah.
confirmed ELISA positive
Yeah.
for HIV virus. So that's not a hypothetical, that's not a, and I still don't understand why you couldn't have designed your study where you could have had, since the biological is separated from the survey, that you could have just assigned it an anonymous number and given the subjects the potential option to call for the results with a trained research staff that is knowledgeable about the significance of a positive ELISA as opposed to a positive Western blot and a confirmatory.
Sure. But in many settings, someone may not have a phone. In many settings, if a wife is tested, she's not, from last week's talk, she may not be allowed to go and get health information. So maybe the husband, so there's a lot of, right. We have very good anonymous, test results provision in this country.
One question for you. I know this is probably a real situation. In looking at the informed consent document, if I were looking at this from the RRB perspective, I would want to be sure that those who are positive, if they want to know, that you actually can send them to a place where they can get counseling. Because you could tell somebody they're HIV positive, they could go jump into the lake.
Yes, and I'll get to that.
So
that's
those
coming
are
up.
important things that you need to, looking at it, how are you going to handle people who are positive? What are you going to do to protect them from themselves?
Right.
And some want to know, some don't want to know, and some you have. That's our job as
right. And it gets even more complicated outside of the U.S. where it's individual care, doctor-patient relationship. In a lot of settings, it's the elders know your health status, and how do you disclose to elders? How do you tell them? Do you tell the individual? Different things like that. So let me start getting into that a little bit to make it a little more complicated. So in India, at the societal level, should you not give test results as part of or should you bypass the test result provision, consenting individuals stating that it's not going to be part of the study because of significant stigma. When I first started going to India in 2001, they were still, burning the beds of the patients with HIV in the hospital. So is that enough stigma to, we're trying to determine rates and set up policy to just bypass that, and if people are really interested to go there to get their own tests at a voluntary counseling and testing center. There's history of throwing spouses out of the house, so a spouse who is not, who consented to a study or, just consented to an HIV test, the husband gains the knowledge, and, even if the husband is the one who was first infected, they, throwing out the spouse out of the house. A lot of suicides. Here in the U.S., we always talk about the importance of voluntary consent and voluntary counseling and testing because of this issue of maybe suicide. And so you talk about you try and get from the individual. So what would happen if you found out that you were positive? And that is probably, and Renzo can probably speak to this, being around and testing patients early in the epidemic. How real was that risk? And because we don't really think about it much anymore, and I don't know if treatment really decreases risk of suicide. But in India, there's treatment, and there's still plenty of suicides. So when I lived in India, I'd ride the bus and read the paper, and I would always tear out little. And every day there is some story, either about someone killing themselves. There are three reasons people kill themselves in India. from the mainstream media is HIV related. So someone finds out that they're infected and they've infected somebody else in their family, or somebody else in their family is infected and infected their kids. And then the two unrelated to that are a farmer who there's drought and can't pay the bills. And then the third is a student who didn't get the right test score to get to the next level in education. But this was, so this was every day or every other day was someone killing themselves based on HIV. This is in 2004. Could we argue that in 2010, things have gotten a little better? Perhaps, but there's still tremendous stigma. So what about HIV results disclosure during studies in India? So what happens in India? So I should just backtrack. In the United States, so we basically, the NIH will not accept a study where there's an HIV test done as part of the study and there isn't results disclosure. So we can just get past that step. But so then I want to just transition to...
One can opt for their results or not.
Right. So they just have to have the provision to be able to get the results if they're interested. Right.
But that has, probably because that has public health implications when you're doing that kind of...
Yeah, I mean, there's a number of reasons, I think. Yeah, absolutely. So what you were saying, what people walking around with their HIV status and infecting others is one, yeah. So we did we're looking at this in the literature. So we did we wanted to see in research studies in India where an HIV test is done, are the results provided to the study participant. So we did a Medline search of HIV in India or AIDS in India and got 3,300 articles. Only 515 had an HIV test done as part of the study, so as part of the protocol. It wasn't, hey, you're in this HIV knowledge study and you can do testing as well, but you may not want to. Then we found that HIV status was known prior testing in 2019, so that was excluded. Participants' HIV status unknown before testing, 296. And then basically we got to 266 articles. Of those, 165 were full manuscripts. So the articles, the first author, and this is all articles including brief reports in this table, but I get to full manuscripts in a second. The first author location, predominantly these are Indian authors writing about HIV in India, studying HIV in India. The mean impact factor was 2.1. You see the full manuscript versus letter brief report, and the funding predominantly came from India, was generally institutional funding. So some preliminary findings. So there were a total of over 2 million study participants were tested, of which 42,000 were HIV positive, so 1.9%, of which 14,000, 34.8% were provided counseling and testing, or voluntary, or I shouldn't say voluntary, it was part of the study. So counseling and testing is part of the study. So that's, so 35%. Which says that they're, getting back to this public health issue, there are, close to 65% of the study participants, so 65% of 14,500 who were walking around, presumably, potentially with unknown, they didn't know their own status. Not getting ethics approval, so we also looked at, was ethics approval mentioned, was associated with a decreased likelihood of participants obtaining test results, okay? And voluntary counseling and testing was less likely to be provided if the first or last author's primary affiliation was located in India, in the absence of a U.S. ethics board, or if published in an Indian journal, which leads to some of the biases that could enter this sort of review. Voluntary counseling testing was much more likely to be provided in articles published within the last 5 years, regardless of if they were published by an Indian author, in an Indian journal, or with or without a U.S. ethics board.
So were there any people getting the results without
Good question. Not that was written. Yeah. So IRB approval.
So IRB approval is not institutionalized.
Well, a couple things, and I'm going to get to it. So, true, IRB approval is not institutionalized in a lot of, the major research centers certainly have IRBs and functional IRBs, but there's a lot of community-based work that happens, and there's not necessarily an IRB that governs that, or there may be an IRB in like a totally different part of India, vouching for, it's like Europe, someone in Norway vouching for a study going on in Greece, different languages, cultures, that sort of thing. But this, there also may, the bias that may enter here is that Indian journals may not mention that. The authors that may not be the protocol or requirement of the journal, which I'm going to get into a little bit more.
Excuse me.
Yes.
My understanding is that studies having collaborators from the U.S. must also have IRB approval, not just in the home country where the research is taken, like India, but also in the U.S.
Exactly, yeah.
And all these ones had approval from the U.S.
So, all these. So the studies that were joint U.S.-India study, or where there was an author, a first or last author from the U.S., the overwhelming majority did have IRB approval, but there were still some that didn't.
Is that even in the last 5 years, or we're talking about 10 years ago?
Yeah, I haven't done that analysis yet, but in the last 5 years, there have been changes in the last 5 years.
There's also, sometimes people have IRB approval, it just doesn't get explicitly reported in the methods section. So it meant there was an explicit report of IRB approval.
Yeah.
Or they'll report it from one institution, but not from all institutions. There may be a reporting bias, I guess, to some degree.
Right, and the U.S. IRB, there may be, those who are, they undergo HIV voluntary counseling and testing, which may mean something different to an IRB reviewer here than what's actually happening on the ground. Yeah. So what we're doing now is we're harassing all of the authors to find out where there's information not provided in the manuscript. This was IRB approved, by the way.
Vulnerable human subjects, or why does that require?
Well, there could be just maybe.
You're going to publish it. Right?
Yeah, we're going to publish it, and it may be that there may be some pressure felt by some. I don't know, but it was approved, and.
Are there ever studies that don't require IRB approval? What's that?
Quality patterns
Minimum
that are
risk,
published beyond your own institution walls.
Surveys.
For public information.
Those still get IRB approval. They're
Or
just
exempt,
waived.
or-
They're exempt, but
Yeah,
they're
right,
designated as exempt by the IRB.
Right.
Yeah.
You have to submit everything. But studying authors of scientific research papers to find out why they left information out would require this wasn't even an expedited approval?
Written consent. No, I'm kidding.
It was minimal risk, right? So it's expedited.
It was expedited.
But not exempt.
I think it's good that
I don't know.
the researchers deserve protection from research also.
I'm not making a judgment, I'm just asking a question about, is it ever?
There were some,
What kind of protection within it? Asking.
There were some things that. Okay, so let me give you an example. Like if somebody, we first sent out emails, sent out three emails if they didn't respond, and then we followed up with another 3 emails, and we did letters, and now we're in the process of contacting them in person, either face to face or over the phone. So, but what can come up is, so say an author says, we injected HIV into these patients, or something crazy, there are things that could come up that might be sensitive, and if it's not, and maybe something that would need, consent to
Or I
provide.
could sue you for harassment, because if I didn't respond to the 3 emails, the 3 letters, now you're coming to look for me face to face.
At your house, yeah.
Get a lawyer, a letter from a lawyer or something.
They were supposed to have, right?
Yeah.
Right?
Yeah.
It could be the regulation was they should have and they didn't. and
Right.
they published
That's
it.
right.
Sure, sure. Yeah, we're trying to have equipoise here. Okay, so some of the rationale from the investigators, we basically, the main data we collected was, did you provide consent or not, and was there ethics approval? If so, where? But we also asked for comments, and some of the rationale for not providing, and there's a lot of information of why they shouldn't provide, but some of the rationale was worries about communalism. So, one of the investigators said that, say we gave the results to this family, and like the wife got, killed or something, or thrown out of the house, and then the media gets on it, and then there's riots in the village, and then when our staff is out there, they hurt our staff, and et cetera, et cetera, et cetera. So kind of this communalism that is, it happens in India. India at times can get violent very, very quickly in specific areas. Worries about confidentiality was a big one. So we don't know, we don't have a setup where you call a number and ask a magic question, answer a magic question and get your results that way. Could someone get your question? A lot of the questions we usually use is what's your favorite Bollywood star, and maybe they someone else in their family knows, and so things like that. Cost was an issue, and then one of the overarching messages was that there's really no guidelines that are pretty direct and no standard from NACO is the National AIDS Control Organization, and ICMR is the equivalent to our NIH, the Indian Council of Medical Research. So there's kind of mixed messages. So let me just give an example of the National Family Health Survey, which is a multi-round survey which started in 1992 in India, and it gathers a lot of information on especially child and mother health. Multiple funding agencies, including U.S. agencies, and right now they're on the National Family Health Survey number 3, which was done a couple of years back, which is a nationally representative sample of 200,000 study participants. So the participants in this study were tested for HIV with an unlinked structure and results not provided. And this is a study that, it's the equivalent of like our, what's it called? Just think of the largest health survey in the U.S. Well, no, like what's the National Health? NHANES, right? NHANES. It's like our NHANES, and so everybody analyzes this data, publishes on it, and this data was very important to, if anyone's been following the UNAIDS estimates of HIV in the world. Part of the reason there was a big drop in HIV was because India was overestimating the rates of HIV infection. Their confidence interval was huge. And so this study actually helped us get a better handle of what's going on with HIV infection in India. So these were some of the estimates that came out of it, just to show you, different states and their HIV rates. This was a study I was associated with. A population-based study of human immunodeficiency virus in South India reveals major differences from sentinel surveillance-based estimates. So right before the NHFS data came out, there was data from this that examined or that found that HIV rates were lower than previously thought. This was a large study, over 13,000 participants in urban and rural Guntur district. They got blood spot testing, so door-to-door blood spot, which was tested for HIV, herpes, which is HSV2, and syphilis. Their incentive for participating in the study is they would get a hemoglobin estimation. So on the hemoglobin card, there's a rough scale of what your hemoglobin may be, and if the participant was found to be anemic, there's vitamin and iron supplementation. those interested in HIV/STD results were referred to the nearest voluntary counseling and testing center, so they weren't provided their results as part of this study. This was approved by the Administrative Staff College of India, which is a very large kind of health services institution. The Nizam's Institute of Medical Sciences, which is a premier kind of government/private center. And then the University of Chicago approved a secondary analysis of the data after it was already collected. So I joined the study, kind of midway through. However, we have a round 2 that's slated to start in April of 2010, where we're going to go to every household again and do the same. We're trying to determine incidence. So the question comes up is, should we provide test results?
Before you do that, is there any education in the village or town or the TV? What the reason of the research? Somebody comes to my house and wants to test me, passing my dog or something. And really, what type of information is from consent from the community? I mean, what type of involvement?
Yeah, so they have street plays and they do some preliminary local. The local NGOs. Okay, so there's like people living with HIV/AIDS is an NGO, and they have shops in basically every district in India, and so there are street plays and kind of general HIV awareness and knowledge campaigns in this exact area, but. There was no, to my knowledge, the first round, there was no, kind of community engagement about this study is going to take place and expect someone, to come to your door.
What did people do? They just open the door and begin to test it?
Yeah, so India, this is India. You.
No, this is, I mean, I don't know. Were Indian people testing Indian people, or?
Yeah, Indians were testing Indians, and they had a amazing response rate. It was like high 90s of participation rate, I should say. So people were very welcoming, and it's an official study, and people are welcoming and eager to participate. Full informed consent, which was tested and in the local language. If they couldn't sign their name, there's thumbprints, etc. Yes. Yeah. So, so names could not be linked to results. Okay. So let's talk about some of the guidelines. Actually, I should say, let's talk about some of the exciting things that happen with ethics in India. The Indian Council of Medical Research says that at the onset, that study investigators can decide whether the bold in italics is mine, individuals identified a particular risk during the course of the studies would be informed. Okay, so it's up to the investigators to decide whether the test results should be given to study participants. Interestingly, it may also be necessary in some instances to inform the concerned family members about the results. Getting back to spouse at risk and that sort of thing. Which there was a landmark case in 2002 that the High Court stated that in addition to not being able to get married if you were HIV positive, anyone with an HIV positive result, you would have to identify the family members, which was soon not overturned, but just kind of scuttled aside. Yep.
You can't get married in India if you're HIV positive?
You couldn't for a period of time. Yep. Well, people did. I mean, legally you couldn't. Yeah. It may not always be possible to communicate study results to individuals, ICMR states. But they distinguish between an individual right and kind of a group right. So but research findings and advice should be publicized by appropriate available means to the community at large.
Excuse me. Possible? How do you mean? Possible to contact them, or because if it was possible to get them to participate in the study. It should be possible to let them out.
Absolutely, absolutely, yeah. I mean, anything's possible. Yeah, but, you know, I mean, possible, it may not always be possible to assure confidentiality, maybe. You know, but yeah, you're right, you could. So are there any kind of particularities about India that make this ethics statement from ICMR, or the rationale behind it? I mean, you know, they obviously are very intelligent, you know, bright researchers. They consult with a lot of international organizations and ethics boards. There's NIH grants that, you know, do ethics training and ethics consultations. So is there something beyond just, you know, just the lack of testing? So medical consult. So a lot of people have thought that maybe this sort of idea comes from, you know, just, you know, what occurs. The medical system is very different in India. So, you know, medical consultations are commonly characterized as paternalistic. Doctors make decisions on behalf of patients who often display almost blind faith in the doctor. So there's been a lot of good qualitative and quantitative research that looks at this issue. In private practice, HIV communication is prescriptive and falls short of best practice standards as upheld by national guidelines. Okay, national guidelines are the National AIDS Control Organization guidelines. And disclosure is sporadic and dependent upon practitioners' apprehensions about dealing with patients' emotional reactions. So the concern of, you know, they're going to be too upset and kill themselves, or, you know, their family will be upset, etc. They won't be able to get married. These authors suggest that uneducated, poor patients and women are perceived to be generally incapable of comprehending information and making independent, informed decisions. And societal norms and hierarchies govern social interaction. So some of this work just, I just put it here to suggest perhaps why research results are not, HIV test results are generally not provided.
Are there other communicable diseases that were a large stigma attached in India that have now kind of crossed over and have more acceptance within the community? Like what happens with tuberculosis, or what happens with other sexually transmitted diseases? Are there any other models that could be implemented so that the hurdles that you're facing with HIV research and outreach in the community can be?
Yeah, I mean, that's an excellent question because, yeah, TB, leprosy, they've all been very, very stigmatized. And now they still are, though, more, you know, more, I mean, even diabetes is stigmatized. I mean, you can't tell your soon-to-be spouse, you know, the family keeps it secret, you know, before you're married. So there are a lot of these sort of issues. But yeah, it would be very interesting to see, you know, how I haven't looked into it to see how TB fares, you know, but that would be interesting. So policy guidelines about disclosure have been developed in Western settings and have been implanted vertically and without adaptation, largely in places like India. And this goes with all the HIV voluntary counseling and testing is really a Western model that's been set up in India, and there's lots of problems with it. And successful approaches to HIV policies, and there's some examples from Africa, must be rooted in the local situation. Additionally, there has to be coherence in policy projection. So you have two government agencies saying different things, okay, which can provide confusion. So then I just want to end with these two questions. So how should a U.S. IRB proceed in a situation where a U.S. collaborator is involved in a study where results are not to be disclosed? Okay, that's one. And I kind of give my framework. And then what should a U.S. investigator do? I just kind of want to open that up to discussion.
I'll make a comment. I think that I agree completely about sort of the transplantation of our methods and practices being perilous in all different kinds of ways. And yet, I think at the same time, what that's led to is sort of a gradual increasing acceptance of the better parts of the Western standard, if you will. Arguing for example, in that case, disclosure, and for enforcing the rights of participants. So I think, on the one hand, following the local custom and the local ethics committee, which is, I can apply this to our situation in China, I think is the right start, and what you really have to do to continue to collaborate and engage in the work that you're doing. I do think there's also this education process where I wouldn't want to be part of a decision if it were, we'll tell the men, but we won't tell the women because we've never told the women, and they're, and that they have a different way of handling the information in spite of the local cultural reality. So I think that's the tension that goes throughout that. You actually are trying to move towards a more, I think, a more progressive way of managing the issue. But I agree, it's complicated.
I like that idea of following the foreign IRB's lead. It seems less paternalistic to me.
Yeah. Yeah, with the round 2 of this population-based survey that I've been talking about, I've just been pushing and pushing and pushing to get disclosure, and so we finally have gotten to the point where there is going to be disclosure for that study, but and the people I work with are very amazing and talented scientists and and rational people. So it was always a disconnect for me why results weren't disclosed initially. But I think we're at that stage. I
was just going to observe that experienced IRBs from developed countries should also think of minimum international standards, even when the study is going to be in other countries. Because the tendency is for people to take advantage of. You see, one of the points said, I think the previous slide, poor people and women are not able to take rational decisions. I think that's even not fair on them. Yeah. Anyway, independent, informed decisions. But these are situations where there's even no information at all. And that permeates into everything in most of these other countries. They talk about democracy, locally brewed or locally grown democracy or methodology of doing things without following minimum standards. I think from here, scientists or researchers also need to help those people to appreciate the dynamics of protecting the rights and the health of those who are participating and getting scientific results from studies.
John, are these IRBs, constituted the way ours are here?
Yeah. The 2 IRBs I've worked with, one of them has one of the ex-chief justices of the court, of physicians and a couple community members. And the other one is also, similar sort of setup. So yeah, they are constituted, and because they have FWA clearance, and so they have to have a roster that meets whatever our standards are.
I would go for disclosure and second what he said, but if you determine that the risk of disclosure will be because of the education of the participants may not understand or will lead to suicide, for example. If the research push for disclosure, but at the same time, as a branch, bring people that can explain at whatever level of language the risk, or if there is any thought of suicidal, or prepare people for the disclosure a priori. So basically minimize the risk of what the result would mean for the person in the community. I think disclosure should be there, but also as researchers bring some service
resources to it. Yeah.
Because it's not a yes and a no answer in such a complicated setting. That is, there is people who do fire from their houses, right?
Yeah.
What do you do in this? Create a shelter. I don't know.
Right.
Something that will provide a solution.
I'm struck by the lack of disclosure historically, because if you look at all of the international guidance, not India specific, on the respect for persons, you treat the individual within the context of their society, but you have to treat the individual subject first. And the comment that was one of the observations on the prior slide I found really not just paternalistic, but really problematic. And if that is the intent of the researchers, the risk-benefit changes. Because one of the benefits of participating in a study such as this, there is no benefit to the individual, with the exception of the scientific knowledge of those screens that potentially could help their own individual health. And I agree that the disclosure needs to be in a safe context. I did HIV testing and counseling for at least a decade in the bad years, and I had one person commit suicide after learning, and so I'm very well aware of how nuanced that process is. But we have, I mean, if you look at Belmont, if you look at XIOMS, if you look at ICH GCP, informed consent, balancing risk and benefits is always at the level of the individual first. And we know that when we go to other countries, the individual also is part of a society, is also part of a clan, is also part of a couple, a family, etc. But you have to navigate all of those things, and failure to do so, I think, is irresponsible.
Yeah, I mean, navigation, but I mean that last part about family versus
that's why it's
individual.
A lot of work. That's why you should engage the community in helping draft the consent forms and describe the process and things such as that. It's not an easy process, and there are no simple answers. But engagement with the community instead of just studying the community, it is part of participatory research.
Sure.
And I think the key part of this is you need to understand how these cultures are structured. The several layers is a way of protecting themselves. So you have the chiefs, because you can't do anything in some of those communities unless you go to the community leaders. They don't give you consent, but they are they're supposed to be the wise men and women in the society who listen to what you want to do in their community and say, okay, this seems to make sense, and then they give you permission to actually approach people who will still have to give you consent on their own individual basis. And if you look at a lot of developing countries, those are the structures that you see. Failure to respect those and take advantage of it is very problematic for me to.
Okay. Just want to thank Rachel Santosh and Sarah, who helped with the research, and some of the funding agencies.